Goodness, I have a very complicated question with only 1 minute left. How many cases of hospital-acquired COVID-19 have occurred in New South Wales in 2023?
So in terms of the process for identifying hospital-acquired, there is our usual routine IMS notification system where clusters and outbreaks are registered, but at the moment I haven't got collated numbers with me in terms of reports of outbreaks in our hospitals associated with that. But just to reassure you that our hospitals recognise the importance of infection prevention and control measures to reduce the risk of that, and we do actually call out. We are actually seeing an increase in COVID transmission in the community now, and just to alert you to our weekly respiratory report, which indicates that, and we do want to get that message out, that we particularly urge people to stay at home if you've got any respiratory illnesses. Don't go and share them. Please be mindful, particularly don't visit any vulnerable settings like aged care facilities or hospitals. Please just be compassionate when people are wearing masks and are taking other protective measures. And we will be continuing to alert to and vaccinations, probably the other component.
Yeah, thank you. I have lots more questions specifically about hospital transmission of COVID-19, and I'll come back to that this afternoon, Dr. Chant.
Yep. Thank you.
I'd like to come back to Dr. Chant and the issue of COVID-19 transmission specifically in hospitals, not in the community. So I'll come back to this GIPA that I've been sent, and the GIPA of the Epidemiology and Data Systems branch of Health Protection New South Wales stated, it was advised that the information on the source of COVID-19 infection is not required to be reported into the Notifiable Conditions Information Management System, and the information that is available is very incomplete. Why is source of COVID infection not being reported for hospital inpatients?
So I think that, just to be clear, that GIPA, the section you're discussing there relates to, they've answered it purely from other notifications which are coming electronically. Clearly we don't have individual follow-up now, so that was why I was answering the question in the way I did. So from a statewide perspective, we don't follow up the notifications, and that's why the answer to that question, the data system they're talking about, is our state-based notifiable disease data system, which then has electronic feeds from labs that bring in data, and there are some diseases that we do more intensive follow-up, and in those circumstances, things like measles and other things that we would be having phone call follow-up with GPs to find out and make sure that public health action's taken. In terms of the hospital system, I can confirm that in a system in hospitals there's generally infection control practitioners or staff that have got a role in infection prevention and control. Those staff would be alerted to cases of COVID positive cases, and that would same apply for influenza or RSV positive, or a gastro positive, so anything that's infectious in nature. They would particularly be involved in looking at if there was any onward transmission in that setting, and to identify what would be the factors that contributed to that. I can confirm that those infection control practitioners from across the state meet fortnightly, convened by the Centre CEC, and they then share learnings or lessons from any of those outbreaks, which then inform the prevention control systems that we've got in place to reduce the risk. So it's that the answer to that question is we didn't hold that centrally in the particular form because our local health districts and wards are working through a usual process at looking at these cases and managing outbreaks in those settings.
So does the CEC collect and aggregate that data that's being provided?
So the CEC doesn't collect and aggregate in a systematic way. But as I indicated, that when there's outbreaks in wards, they are captured through our incident reporting mechanism. And again, the focus is really on lessons learned that we can share and put in place to improve infection control and prevention systems in our hospitals. We continue to be concerned around the spread of infectious diseases, COVID, influenza, RSV, gastro in our hospitals system, and take steps to minimise that and learn lessons.
That's I was really concerned at some of the reports that came out of Victoria earlier this year, so particularly that for hospital-acquired COVID-19 there was a mortality rate in the order of 10%. With the data that's available to New South Wales Health, are you able to assess the mortality rate from hospital-acquired COVID?
Clearly that has changed over the time, but we recognise that our hospital patients are particularly vulnerable. They're vulnerable by the fact that they're more likely to have significant comorbidities, and we also recognise that some areas have even greater potential risks, like our transplant units, highly immunocompromised. So we don't actually know the exact mortality associated with COVID. There is other infections we're also, interested in. All I can confirm is that we're conscious of taking every step we can to minimise the risk of transmission, and we also have some increased and enhanced infection prevention and control strategies deployed in our very, very high risk services.
Sure. So what are the protocols at the moment in a New South Wales hospital if there's a patient with respiratory symptoms awaiting a COVID test result? What protocols are in place to prevent that transmission in, for example, a 4-bed ward?
In a 4-bed ward, so someone with a respiratory, we've got access to very rapid tests, but if someone had a respiratory illness, there would be segregation removable into a single room, because we, agnostic of whether it's RSV or other things, we will try and do that. There's a whole cascade. Obviously, there may be occasions when there's not an immediate room available, but there's a whole policy document on our website which we could provide around the steps and advice to manage infection control issues in our hospitals that the Centre for CEC coordinates, our Clinical Excellence Commission.
Yeah. I'm particularly interested in this because I've heard a number of cases anecdotally of transmission in hospitals where there were not adequate infection control procedures and patients with respiratory symptoms on a 4-bed ward. I know from my own community at Albury Hospital, we talked about earlier today, regularly runs a deficit of 20 to 60 beds, so moving people immediately to a single-bed ward, it just doesn't happen in practice. So I'm interested, I suppose, in what work's being undertaken to track that, to adapt protocols as required, or to engage staff with P2 respirators, etc. What work's being done?
So all I can say is that the Clinical Excellence Commission has regularly updates the protocols for prevention and control. I think we acknowledge everyone has a role to play. It remains an ongoing risk. These are high-risk settings for respiratory viruses, and although we've been particularly talking about COVID, we're similarly worried about and concerned about other respiratory virus transmission. So all I can just say that we've got those systems in place, but happy to follow up any particular concerns that you've got about particular settings to do that reinforcement of education, training, and look at any gaps.
Thank you. Look, I'll send through some written correspondence about those particular cases.
Thank you.
I am interested now, coming out of hospitals to the community. Obviously, testing rates are now significantly down from what they were at the peak of the pandemic, and particularly with the rapid tests. I imagine there's far less information coming in about emerging strains of COVID. What work is the department doing to monitor the current and emerging strains?
So look, I'm actually very proud of the work that the department's doing. We've had to change our surveillance methods depending on the phase, and so at the moment we are relying on a system called our FRED system, and this is a system that gives us real-time data, relatively real-time data on admissions to hospital for COVID, direct admissions for influenza. We capture bronchiolitis data, so we look at that, and that's actually very reliable. That's probably our best indicator, because we actually have quite high patterns of testing in our emergency departments for respiratory viruses, obviously for diagnosis, but also infection prevention and control. We also look at wastewater surveillance. So our wastewater, we collect wastewater from 4 different sites, and again, that detects the virus in wastewater, so it's a passive system. It doesn't require that. We also look at indicators like aged care outbreaks in aged care facilities, again a factor of when we see an uptick in cases. And we also look at the Commonwealth collects data on antiviral prescribing, and that's a very good indicator as well. So we publish weekly an assessment of the level of transmission of viruses in a weekly report, which comprehensively has all of this data. And at the moment we are actually in an uptick of COVID, so we've seen a longer than usual flu season. We're seeing flu still at flu and RSV at moderate levels, but they're in decline. We're seeing COVID start to take up, and our projections are that we'll see peaks around later towards the end of the year, November, December. And so we are pushing out messages that now is the time that more COVID is around, beware. Now's the time to get vaccinated. According to the ATAGI advice, we are trying to protect our vulnerable settings. We do a lot of work with our aged care providers. We have guidance for our aged care providers, and we ask them to reflect, noting we have to balance the fact these are aged care facilities are residences and asking them, though, to adjust their protections depending on the level of community transmission. And we work with our colleagues in Health and Social Policy branch at liaising with aged care facilities and have specific guidance. So we continue to look at proportionate measures, but we do have a sense, what's most important to us at the moment is telling the community about the level of transmission in the community so they can adjust their behaviours, particularly those that are more vulnerable to severe consequences of COVID infection at this time.
Thank you.